Hello students, today we're going to cover chapter 15 on psychological disorders in general psychology. So just like all the chapters, this is going to be a really general overview, quite a few very brief points on only a couple different kinds of disorders. Mostly we'll go over the categories and a couple different examples within those categories of disorders. But I find students often like this kind of chapter, and I usually like to put this at the end of a course because you have a lot of the background information about how the brain works, how social situations can affect people to lead to things like disorders, protective, or risk factors. So with this, what is a disorder? What does the APA say? Well, essentially, it has to be something that is significant disturbance, and significant there is a little bit of a weasel word. That significance can be from the person's own point of view. This can be from an outside person's point of view, like the therapist diagnosing a person, but significant disturbances in thoughts, feelings, and behavior. So with that, this disturbance reflects some kind of biological, physiological, or developmental dysfunction. So pretty broad there. The disturbances lead to significant distress or disability in the person's life, and that disturbance doesn't reflect any kind of culturally approved or appropriate response to certain events. So a good example for that last one would be something like a grief response. So any given culture has kind of the pattern of how you deal with grief. But if you're still grieving incredibly after the time period that's culturally appropriate, that might be an example of something that is not culturally approved in response to that event. So let's say, for example, you're kind of expected to get back to work and do the kinds of things you're normally supposed to do within, say, 2, 3 months of a partner dying or even a child dying. So that's kind of an expectation in Western society here in the US. With that being said, if you're still grieving immensely and not able to get to work, not able to get food for yourself, that kind of thing after some time, so after that kind of time, after 4 months, 5 months, 6 months, 7 months, that would be outside of what's kind of culturally appropriate. So it is important to take into account what this person has, the kind of expectations this person has based on their culture, the scripts that they have. But again, that disturbance for number three, the disturbance or significant distress, this might not necessarily be obvious to the person. So in cases like addiction, for example, that kind of distress or disability to the person's life might not be obvious to them. So another thing to make a point of as we get into this material, that unless you are currently diagnosed with a psychological disorder, you probably don't have one of the psychological disorders we're going to talk about. Oftentimes students will see the patterns and the symptoms and have, again, a very general, brief understanding in this general psychology course of these disorders. So just because you notice some little similarities to symptoms, behaviors, thoughts, does not mean that you have this disorder. So these disorders can only be diagnosed by a professional. I don't have the training for diagnosis. I went a different path with my research training to learn how to do research on heroism, prosocial behavior, positive youth development, character education, civic engagement. So I know a lot about those specific topics. I've got a lot of training there, a lot of training on adolescent and adult development, but I do not know how to diagnose specific disorders. I don't have that training. I don't have that certification. So you can only be diagnosed by a professional. Can't be diagnosed by TikTok, for example. That being said, I do think some of the things that I see on TikTok can be helpful to open up and help people reduce the stigma and understand disorders. But there's definitely a lot of people on there who are self-diagnosed, and you probably should go to a professional before telling all of their strategies for how to deal with their disorder. So get professional help if you have any kind of concerns. Oftentimes I'll see students who see the symptoms of, say, schizophrenia or borderline personality disorder. or other disorders like dissociative identity disorder and pick up on little things and say, oh, I definitely have this disorder. Those ones that I just mentioned are fairly rare, so you probably don't have those. So if you see some similarities to, say, anxiety or depression, those are much more common in the population. So if you have a concern about those, definitely talk to a professional. But again, this chapter isn't going to diagnose you. All right, with that being said, hopefully that's enough of a preamble about you probably don't have a disorder. That took a little longer than I wanted it to. But let's talk about some difference between psychologists and psychiatrists. So psychiatrists over here on the left, they are medical doctors. They went through medical school just like a podiatrist, just like a gynecologist, just like a family doctor. They went through medical school. They did a specialized residency in psychiatry. So they might have had the plan to go into psychiatry before then, but essentially for medical school, a lot of things are very standardized. You're going through like the same kinds of classes. And then in your residency, you're getting more specialized training. That being said, for a psychiatrist, they are going to be trained with things like chemistry, pharmacology, whereas a psychologist will not be trained in chemistry and pharmacology. So a psychologist is someone with a PhD or a PsyD. So PsyD is right here. That's how to say that. And it's basically another psychology doctorate. A PhD is a research degree. You've learned how to do research in psychology in a specific kind of area. So you have a doctorate that way. A PsyD is a lot more practice focused. So you've got a lot more hands-on training. So a abnormal psychologist or a psychologist with a PhD in abnormal psychology has training in research around treatments, diagnostic criteria, tools to diagnose people, and they do have some hands-on training with patients. And for a PsyD, it's a little bit backwards. The PsyD has more hands-on training with patients and less of the research. So that's PhD, PsyD. You're going through, say, master's and PhD program or master's and PsyD program versus medical school for a psychiatrist. Next up, some of the main things that we see is psychiatrists, one of their primary things that they do will be identify a particular disorder and so actually do some diagnostic tests to see what disorder you have. That being said, psychologists with specific training can do this as well. If you're talking about someone with like a master's in social work, they might have to give you a diagnosis after a first meeting, but they might not be trained specifically in some. So usually a psychologist, so here on the right side, cannot prescribe medicine. There are a few states where they can. They have to take some pharmacology classes and chemistry classes to be able to do that. But Washington, as of this moment, is not one where that is possible. Psychiatrists, on the other hand, can prescribe medicine. And that's oftentimes the main task that you will be going to for a psychiatrist is you will come into usually a shorter appointment with a psychiatrist. They will check how your medicines are going. In a first appointment might be longer to start to try and diagnose, but after you have a diagnosis, after you have some medicines, most of the appointments will be shorter, maybe 15 minutes long. Come in, talk about side effects, talk about anything that's been bothering you, and any new things in life that might lead to differences that we might need to change your medicine. And then if there's no problems, send you off on your way with a new refill. So those appointments tend to be very short. There's not really any kind of talk therapy. As we talk in chapter 16, like cognitive behavioral therapy, a psychiatrist is probably not doing that. They could go for specific training to do it, but usually they're not. Versus, on the other hand, a psychologist is going to be doing that kind of talk therapy, helping people. Appointments are going to be closer to 45 minutes, and you're going to be working through problems, building skills, setting goals with the psychologist more than the psychiatrist. Oftentimes, psychiatrists are working with or alongside hospitals. Maybe even your visits are at a hospital. Versus a psychologist, you might be connected to a hospital. You might have your own private clinic or be part of a clinic group. Also, masters of social work are very similar that way too. And oftentimes we see that psychiatrists earn a little bit more than psychologists, even across different states. So, with that being said, jumping back to abnormal behavior, this is behavior that's deviant or atypical in some fashion, maladaptive or dysfunctional in some fashion, and personally distressing in some fashion. So, deviant can be just statistically anomalous. So, this is a behavior that it's pretty rare that we see, or it could be deviant based on the cultural norms. So, if you're breaking windows all over town every day, that might be seen as deviant depending on your cultural norms. Maladaptive is disrupting a person's ability to lead their day-to-day life. This could be things like they're not able to sleep, they're not able to get to work, they're not able to interact with their friends very well. There's a lot of things that might look maladaptive. Another thing could be that they're putting themselves or others in danger. And then personally distressful, again, any given thing, it might not feel personally distressful to the person, but over a varied period of time, depending on the disorder, depends on kind of how long the period of time we look for is. And the patterns of behavior may cause people to feel guilt, shame, despair. It's uncomfortable. They don't like it. With that, they might not realize that they have a disorder, but that might explain why they're feeling that way. Again, you can definitely have something like a disorder, let's say addiction, for example, and not realize that you have a problem and an addiction. It's not personally distressful to you, but others see the kind of problems in your life so that it's maladaptive to you. So, what we use in the US is called the DSM-5. This is the Diagnostic and Statistical Manual of Mental Disorders, and that is what we use here in the US. It's essentially a pretty detailed checklist of a lot of things to help us diagnose disorders. So, it will give you an overview. You're not supposed to have access to the DSM-5 unless you are a trained clinician. So you can find older copies. I've seen some in like thrift stores, like DSM-4s, for example, or there's pirated copies as well. So you can access it, but you're not supposed to unless you have that kind of training. But what you would see is the overview of the disorders, the specific symptoms required for diagnosis, and any given one might say you have to have three of these four, or you need to have seven out of these 14 symptoms to then qualify for this disorder. Prevalence information across the US for different genders, risk factors, so things that make it more likely that you could develop that disorder, and in some cases, risk factors if you have that disorder to watch out for as well. Comorbidities are essentially co-occurring disorders. So two that we've probably talked about quite a few times in class, anxiety and depression, those are comorbid. They often happen at the same time, and so you might get specific treatments for each of those pieces. So it will tell about common comorbidities to give the therapist some ideas of what to be looking out for. But again, the main idea here is to try and help diagnose people with those disorders with this kind of detailed checklist. There are other classification systems used by other places in the world. So the IDC-10 was developed by the World Health Organization. One thing that it adds is some more culturally relevant statistics. So prevalence information different by different places in the world. So like South versus West Africa versus Central Asia versus Pacific Islands, that kind of information, as well as a little more culturally relevant information too of the kind of expectations of given cultures. So with that, we do have some reasons for having this kind of classification system. It really helps to have a common basis of communication about a disorder. If you move to a new place, if you have to switch therapists, it's very helpful for a new therapist to open up your files, see your diagnosis, see the notes that the person has. It gives them a really easy way to communicate that. It also helps make predictions if we have these categories of disorders and the expectations of kind of outcomes and things like that. And also, naming a disorder can provide comfort for an individual who gets that diagnosis. Being able to put a name to that can be very helpful, very soothing, very calming. They can look up resources for people that are similar to them, that are struggling with this. That can be really helpful. But there are disadvantages too. There is still a lot of stigma on a lot of different disorders. When we talk about something like schizophrenia or borderline personality disorder, These things still have a lot of stigma to them and negative reputation. So it might not be great to find out that that is your diagnosis. It might even cause you some cognitive dissonance. So another piece of the DSM-5 itself, it does treat the psychological disorders mostly as a medical illness. So it's very biological focused, even though a lot of these things have a lot to do with the biology of the brain. But these are things that with our brain we can work through with, say, talk, practice, building new skills, things like that. So it really does take a very focused biological perspective rather than a little bit more sociocultural perspective. Another thing, it does ignore strengths of people with disorders. It really focuses on the problems, challenges, symptoms. Um, and another piece here that's listed is promotes overdiagnosis. That could be true just because there are these diagnoses, and sometimes they're a little wrong. Some of the most common disorders that are misdiagnosed, things like PTSD, ADHD in children, uh, borderline personality disorder is one, generalized anxiety disorder. So oftentimes the anxiety is not really actually generalized, it's maybe more specific. So those are some common ones. So it might promote overdiagnosis of some of those. But really, I think this comment or this bullet point really has more to do with the insurance system of the US. A lot of therapists, whether it be Masters of Social Work, a PhD, a psychiatrist, after that first visit, you kind of need to have a diagnosis for your insurance to be covering the visits. And so it does encourage people to make a diagnosis. And it might not be correct at first. You might have forgot aspects of your medical history. You might have forgot that your one of your direct relatives had a certain condition that's likely genetic. So if you don't have that on the list, they say, well, it's probably not this because they don't have that in their family history. These are things that can then change diagnosis later when the therapist assessing you knows more about you. With this, it does come from a Western cultural context in the DSM-5, so these are some disadvantages to it. Just like we talked about early on in this class, this chapter really takes a biopsychosocial approach. So, biological being genetics, biology, psychological, the thoughts, emotions, personality, cognition things, sociocultural, the social context. So, we've talked about this before in class. The idea behind any of these given pieces of looking at disorders is that biological might affect it, the sociocultural might affect it, and the psychological approach or psychological factors might affect any given disorder. And so the job is to, one, figure out what kind the disorders are. Some of them are a little more heavily genetic, some are more heavily sociocultural, some are more heavily psychological. So figuring that out is a big piece of that, but understanding that they are overlapping, they do interact. So another piece here is the diathesis stress model. So we've talked about stress in class before. Stress can make basically any disorder more likely to occur. It can make symptoms of any given disorder worse as well. So that is the idea behind diathesis stress model. You might have a predisposition or a risk factor already towards a disorder, to developing it, for it getting worse. And then you have some stress, makes the disorder appear. So we'll see a couple of concrete examples of that as we go through. And another thing that we can look at with this biological and diathesis stress model is the percentage of people who end up with a disorder based on their genes. So there is genetic components here. Comorbidity is essentially when two disorders are happening at the same time. Again, there's a lot of them that are very common to be comorbid with one another, and some that are less common and being comorbid with one another. But now let's jump into anxiety disorders. So here we have a short list of different types of anxiety disorders. This is not an exhaustive list. This is not all of the anxiety disorders. For each of these, there is a lot of information in any given slide. Some of them I'll focus on a little more than others. But essentially, with these, we're oftentimes using that brain pathway for flight or fight responses, the hormones and brain networks to help you respond to stress. So generalized anxiety disorder is persistent anxiety for 6 months or more. That's one of those criterias in the DSM. You would make a check mark. Have you felt this way for 7 months, 8 months, that kind of thing? If not, it might not be generalized anxiety or might not be yet, or it might not be able to be defined as that yet. And the big thing here for generalized is there's not like a specific cause for the anxiety. It's a bunch of things together kind of built up. And there are genetic factors here. There are biological predispositions. We do see some hormones and some neurotransmitters like GABA related to generalized anxiety disorders. But we also see some psychological and sociocultural factors. See things like people with high self-standards, having critical parents, having negative thoughts, having trauma. These are all risk factors for developing generalized anxiety disorder. So for any given person, it might be more genetic or more the critical parents or more their harsh self-standards with a GABA deficiency. Right, so these are pretty common pieces of the puzzle to develop generalized anxiety disorder. So from that, another example of an anxiety disorder is panic disorder. This is essentially a disorder marked by having frequent bouts of intense panic without necessarily having specific triggers for them. So maybe panic attacks without certain kinds of triggers. They can also have triggers as well. And we've talked about panic attacks a little bit in the class before, but here's a quick review of what your body is doing during a panic attack. Another example of an anxiety disorder is a phobic disorder. And so you can hopefully see how different this is from generalized anxiety disorder. A phobia, you have a specific fear about something. You have something you're specifically incredibly anxious about versus generalized anxiety disorder, a generalized anxiety that's kind of there all the time. So with this, there's a lot of different kinds of phobias. There are some genetic dispositions to be able to develop phobias. It's a lot easier to develop phobias of the spider, rat, and snake that are on the screen. There might be some evolutionary component to that, but you can develop other phobias too. So here's again, not an exhaustive list. So thalassophobia is not on there, and that's one that I would probably not be at the stage to be diagnosed with a phobic disorder, but I definitely have some fear of like large creatures in the water, uh, even though they're pretty cool, like whales and stuff. They're cool, but scary. Here's a couple examples. So again, some of these might have some evolutionary components, but a fear of vehicles driving, there's probably not been anywhere near enough time for us to develop that as I mean, pulling carts has been around for a while, but we probably don't have an evolutionary component to develop that. Some phobias can be learned just from learned behavior, having behavioral interaction, having some trauma with driving vehicles or other things as well. Clowns, for example, you might have learned to have a fear of clowns over time. You can also learn phobias vicariously. Even if your parent doesn't actually have a phobia, if they talk about being scared of something like whales in the ocean or something, and maybe you develop a phobia from that vicariously. So, obsessive compulsive disorder is another different example of an anxiety disorder. Again, here we are still using that kind of anxiety loop in the brain and the hormones. These obsessions are these intrusive thoughts, these urges to do a compulsion, a behavior. It's usually a repetitive behavior. And if you don't do that behavior, you're going to feel a lot of anxiety. So, some common examples are things like washing hands, checking locks on doors, checking ovens, checking your car locks, right? These are things that you might have a specific pattern to lock things a certain number of times and every night, and you cannot get to bed. You have to do the thing. So that would be a compulsion. And those intrusive thoughts are you're just thinking about it and you're feeling anxious and you know it doesn't make sense because you've already checked the car 3 times. So you don't actually need to do it, but you feel that anxiety. So it is an anxiety disorder, even though the behaviors that you see from it are a little bit different than something like panic disorder, or generalized anxiety disorder. So hopefully you can see this general category of anxiety disorders and kind of where they fit. So some similarities with like body dysmorphic disorder. So that's kind of seeing yourself differently, having some distorted self images, and then also doing some repetitive or ritualistic behaviors, whether that be something like binging and purging for, say, bulimia. Hoarding disorder is also an anxiety disorder. Post-traumatic stress disorder, again, kind of puts together a couple of the pieces that we've talked. It is usually tied to a traumatic event that you have experienced, but it can also be vicarious. We see, especially a lot of therapists get PTSD vicariously from listening to other people talk about their traumas, and then they have PTSD from that trauma. So with this, that event creates the stimuli or multiple stimuli and things that lead to the increased stress over time and the anxiety. So with this, we see that there are disturbances in memory, negative appraisals for the trauma and its aftermath. And a lot of it is just kind of classical conditioning, negative things happening together with the trauma. And we see that there's a lot of risk factors for PTSD. So, again, a lot of these things are related to being more likely to develop PTSD. But hopefully, you can see some of the similarities and differences with PTSD versus phobic disorder versus generalized anxiety disorder. Again, each of them is an anxiety disorder, and each of them kind of presents in a slightly different way. And that's why it's important to figure out with something like the DSM-5 exactly what disorder you're dealing with so you can treat that specific thing. The next one we'll talk about is mood disorders. So, when thinking of mood disorders, think about our discussion on emotion and mood in previous weeks. So, emotions are pretty brief in general, moods are more diffuse states similar to emotions, but they last a little bit longer. So, a variety of mood disorders are things like depressive disorders, bipolar disorder, also suicide. And these are basically things with cognitive, behavioral, and somatic symptoms, which also lead to interpersonal difficulties. And there's a wide variety that are not included on this list. So this is just a brief list. There's multiple types of depression as well. We'll touch on a couple of them. But major depressive disorder is a fairly common disorder around across the world. And with this is characterized by sadness, loss of pleasure in usual activities, and this can also be, so those would be two like critical things to look for in the DSM-5 for this kind of diagnosis, but also weight gain, weight loss, feelings of worthlessness or guilt, suicidal ideation, psychomotor agitation, which is basically like physical things you might do. It could be things like twitches or repetitive behaviors, falling asleep or difficulty falling asleep too much or difficulty falling asleep, and then difficulty with concentration and decisiveness. So, with this being said, major depressive disorder is a hard one for people because it's often a tough one to reach out with. So, that lack of motivation and lack of pleasure in usual activities, oftentimes feeling worse, a variety of the combinations make it very hard for people with major depressive disorder or other types of depression to reach out for help. So if you think that is something that someone that you are close to or you are in their network might be suffering from, anything that you can do to help them be able to reach out, even if you ask them if they would like you to reach out for them, could be a really helpful thing. So with this, there's some pretty obvious risk factors here. Living in poverty is going to be a big risk factor for developing major depression. So also things, major life events like being separated, divorced, or widowed are another risk factor. Being unemployed or becoming unemployed is a big risk factor as well. So there's a lot of comorbid disorders here. Depression can obviously be caused because you have distress because of other disorders. So your struggles with another disorder might cause you to also develop depression. But like we mentioned, anxiety disorders, also substance abuse disorders, are fairly common with depression. With this, it Also, people who are unable to do work or complete school often are faced with discrimination, and that can be a risk factor as well. And depression itself is a risk factor for other negative health outcomes too. So, a couple other subtypes of depression that you're probably aware of. Seasonal affective disorder. At the time I am recording this, there might be a lot of people experiencing seasonal affective disorder. During the time of the year where there's not as much sun, and that is usually lasting for seasonal affective disorder just during that time of year. But postpartum depression is another example of a different specific type of depression, and this is when those postpartum blues after birth continue on past just a couple weeks and become postpartum depression. Again, same kind of symptoms in the end, but is kind of this triggering event. And sometimes depression has a triggering event, just like sometimes anxiety has a triggering event. So persistent depressive disorder, you might have also heard it be called chronic depression, is kind of that kind of mood disorder consistently for a long period of time. So bipolar disorder is oftentimes mostly characterized by depression. So it is a swing or a vacillation, as is described in the slides here, between depression and mania. But you can also go from depression to not depressed back to depression to not depressed. You don't have to go from depression to mania. There's many people, often mania is one of the least common pieces to go to, but it is something that some people get to. So mania is an extremely cheerful, euphoric mood. Oftentimes people are very talkative, very irritable. They've got high irritability and high activity levels. You might see someone who's in a manic phase of their bipolar depression or their bipolar disorder, trying to take on tons and tons of tasks. And in some cases, they're able to do those for a certain amount of time until essentially their body can't handle and needs to sleep, things like that, and they will crash oftentimes. So manias tend to last not as long as depressive episodes as well. But even with that being said, we see that a lot of times with bipolar disorder, people have an incorrect assumption about how quickly people switch between mania and depression. For bipolar disorder, this rapid cycling bipolar, it's called rapid cycling because it's much faster than the common cycle. The much faster than common cycle is 4 or more episodes of mania or depression in 1 year. So again, that could be depression to not depressed, depression to not depressed, depression to not depressed, depression. So that was, I think that was 4 that I just mentioned there, or making one of those a mania phase. So that's like 3 months consistent of that mood or about that long. So when you hear someone say something like, oh, that person's really bipolar, they switch on like a light switch. That isn't actually what you would expect from someone suffering from bipolar. Also, that's a really terrible thing to say, to use bipolar as an insult like that. Really disheartening for someone who might have bipolar or family with bipolar. So with this, depression is the most common kind of phase and experience. So oftentimes a primary treatment are the same treatments as depression. But hopefully that makes it a little more clear what we expect from bipolar disorder. Borderline personality disorder is an example where you might more commonly expect quicker changes in mood and emotion. You might see someone with borderline personality disorder who is your best friend one day and hates you the next day. That is not uncommon, but those kind of extreme emotions are more common with something like that, even though that is still, and so that's different than this bipolar depression. So a couple other mood disorders and some causes of mood disorders, we see a lot of connections with neurotransmitters like norepinephrine, serotonin. That's why a lot of medicines kind of target those specific neurotransmitters. We also see some brain areas being overactive or used more and more, kind of a network that leads you to depression or rumination. And this also includes things like amygdala. So a lot of these disorders you build up over time versus because of it, genetics, because of the experiences you've had, whether it's PTSD, whether it's depression. A lot of times people have a network in their brain that makes them feel that way. It's a network that the neurons, again, they don't know that they're giving you depression. They don't know that that's what they're doing. They just know, hey, I should activate when these other bunches of cells activate. And so those networks are, for a lot of people with a lot of these disorders, kind of consistently running that program for whatever disorder it is. And that can make it really hard. And so that's what a lot of therapies are for, are to stop that kind of pattern, to adjust the brain so it's not going through those kinds of loops, whether it's a rumination loop, whether it's an anxiety loop, these kinds of things. So stress, and going back to that diathesis stress model, that is a really good example here in depression, that it is one that actually changes you epigenetically. So there are specific genes that only activate with stress that would lead you to develop or be more likely to develop depression. So you might have the gene, but if you don't go through enough stress to activate the gene, then you are much less likely to get depression. So a lot of the medicines that we'll talk about in chapter 16 do work at this synapse level, either making the cells make more neurotransmitters, putting fake neurotransmitters in here to activate the receptors, having this cell's receptors stay open longer. There are some that keep these neurotransmitters in this space, so like SSRIs are selectively blocking the reuptake of those neurotransmitters. So in some way, though, trying to get more of the neurotransmitters that we expect might help to the next cell to then activate. So there are other pieces that are important in the cognition of depression. Again, that builds in these like rumination loop. That stress can lead to more negative and maladaptive thinking. Stressful events can make that worse. You can have more negative downward spirals. If you are hopeless in general, so perceiving life events that are negative, or having a sense of hopelessness that you can't change things, that you can't do things like problem-focused coping, that makes it more likely. And then a repetitive focusing on those things that caused the depression or might have caused the depression in the first place. So again, suicide, about a couple of these main factors that I want to point out are that some of these things can be kind of predicted and prevented and helped. So for example, if you know someone who fits some of these risk factors, is withdrawing from relationships, has been doing reckless behavior, seems to be abusing substances, definitely if they've had a previous suicide attempt. If you know they have something like access to firearms or another fast means of suicide, helping them to not have that method, right? So even if state laws, for example, don't allow you to take a firearm, you can disassemble and take pieces, like say a firing pin from a firearm. Locking things up can make things give a little bit more time that a person can get out of that kind of loop and make it more likely that they can survive. So these are things to look for. There are a lot of networks, a lot of programs, a lot of numbers and things that you can use to support people who are going through depression, suicide as well. One of the most misunderstood disorders that I definitely want to spend a little bit more time on is schizophrenia. And one of the first things that I would like to do is share 2 quick videos of a couple people's experiences, or a couple minutes at least, of a couple people's experiences with schizophrenia.
Look out the window. I'm trying to show people the experience of schizophrenia with a lot of people is that everything is alive, and you can't choose that perception. It's an artistic depiction of how it feels both emotionally and kind of overwhelmingly. I was in my second year of university, and I remember I'd be in class, and I was doing like art school, and I would have to leave the class, and I didn't know why, but I just started going underneath like the staircases at the end of the building and just hiding. And I remember in those moments it wasn't voices yet, but it was intrusive, like if intrusive thoughts had life to them. I started hearing just little like laughter here and there, like little shrieks and little things. And I just kind of thought to myself, okay, well, like this is weird. I feel like I'm like, is this tripping? Am I tripping? And I got really confused. I dropped out of university because I couldn't deal with it anymore. I remember it ended up in me being homeless and traveling around my province in Canada. It's New Brunswick.
So I definitely recommend watching the rest of that video. It's a really good one talking about their experience. I think you might find some commonalities with the first part of this video as well. This one's a lot longer, but we'll watch about the same amount of time. Just the first couple minutes of this. Again, a person with schizophrenia talking about the beginnings of what they were experiencing with the disorder.
The day I left home for the first time to go to university was a bright day, brimming with hope and optimism. I'd done well at school, expectations for me were high, and I gleefully entered the student life of lectures, parties, and traffic cone theft. Now, appearances, of course, can be deceptive, and to an extent, this feisty, energetic persona of lecture-going and traffic cone stealing was a veneer, albeit a very well-crafted and convincing one. Underneath, I was actually deeply unhappy, insecure, and fundamentally frightened. Frightened of other people, of the future, of failure, and of the emptiness that I felt was within me. But I was skilled at hiding it, and from the outside appeared to be someone with everything to hope for and aspire to. This fantasy of invulnerability was so complete that I even deceived myself. And as the first semester ended and the second begun, there was no way that anyone could have predicted what was just about to happen. I was leaving a seminar when it started, humming to myself, fumbling with my bag, just as I'd done 100 times before, when suddenly I heard a voice calmly observe, "She is leaving the room." I looked around and there was no one there, but the clarity and decisiveness of the comment was unmistakable. Shaken, I left my books on the stairs and hurried home, and there it was again. She is opening the door. This was the beginning. The voice had arrived. And the voice persisted. Days and then weeks of it, on, narrating everything I did in the third person. She is going to the library. She is going to a lecture. It was neutral, impassive, and even, after a while, strangely companionate and reassuring. Although I did notice that its calm exterior sometimes slipped, in that it occasionally mirrored my own unexpressed emotion. So, for example, if I was angry and had to hide it, which I often did, being very adept at concealing how I really felt, then the voice would sound frustrated. Otherwise, it was neither sinister nor disturbing, although even at that point, it was clear that it had something to communicate to me about my emotions, particularly emotions which were remote and inaccessible. Now, it was then that I made a fatal mistake in that I told a friend about the voice, and she was horrified. A subtle conditioning process had begun. The implication that normal people don't hear voices, and the fact that I did, meant that something was very seriously wrong. Such fear and mistrust was infectious. Suddenly, the voice didn't seem quite so benign anymore. And when she insisted that I seek medical attention, I duly complied, and which proved to be mistake number 2. I spent some time telling the college GP about what I perceived to be the real problem: anxiety, low self-worth, fears about the future, and was met with bored indifference until I mentioned the voice, upon which he dropped his pen, swung round, and began to question me with a show of real interest. And to be fair, I was desperate for interest and help, and I began to tell him about my strange commentator. And I always wish at this point the voice had said, "She is digging her own grave." I was referred to a psychiatrist who likewise took a grim view of the voice's presence, subsequently interpreting everything I said through a lens of latent insanity. For example, I was part of a student TV station that broadcast news bulletins around the campus, and during an appointment, which was running very late, said, "I'm sorry, doctor, I've got to go, I'm reading the news at 6. Now, it's down in my medical records that Eleanor has delusions that she's a television news broadcaster." It was at this point that events began to rapidly overtake me.
So another good example of someone's experience with schizophrenia And with this, these you can probably see some commonalities. Oftentimes, schizophrenia starts in early adulthood, so most commonly between ages of like 18 and 26. As and with that, oftentimes the symptoms kind of start off slowly. Another big thing is if people are scared of them, if they're worried about them, if they're more stressed, they get worse quicker. Oftentimes, though, they're not. The hallucinations are, with that being said, hallucinations are most commonly auditory. Visual hallucinations are very rare. They're generally for people very just annoying, sometimes disturbing, but not necessarily harmful for most people. Like the hallucinations themselves aren't telling them to like harm themselves or others, generally on average again. So the positive symptoms of schizophrenia, we heard about a couple of those. Positives are ones that are added to a situation. So it's not like this is a good thing, it's that this is added to the person or added to the situation. Kind of like behaviorism, talking about math language of positive and negative. So delusions would be something like if you actually weren't a news broadcaster, if you thought everybody from the CIA was out to get you, right? Something like that would be delusions. Hallucinations, we heard some auditory hallucinations. We saw some examples of visual hallucinations as well. Disorganized speech, if you've ever kind of messed up your speech, you've not been able to kind of get out what you want to say, is kind of like that, but turned up to like 1,000, where they're not really able to get out their speech, and it's very frustrating for people experiencing it. Negative symptoms are things that are kind of taken away from the person. I had a client that had basically all of these negative symptoms of schizophrenia. So very flattened affect. They just basically seemed like they had no emotion at all. Very reduced speech. They hardly spoke at all. A very big lack of initiative overall. So any given person might have a couple of these symptoms, might have all of them together, might have only the negative side or the positive side. But with this, a bunch of the cognitive symptoms as well are attention difficulties, memory problems, especially if you have some of these other pieces, your brain isn't quite putting those memories together, especially if you're having delusions, and makes it very easy to be impaired and make informed decisions. It's hard to do that. And so people with schizophrenia tend to be really uh, targets of crime, essentially. So fairly common targets of crime. If you can say someone has a delusion, you can manipulate their delusion in a way that benefits you in some way. And this is often something that happens to people with schizophrenia, being taken advantage of, financially abused, other types of abuse. It's really very awful. And it's really very hard and challenging. Schizophrenia is one of those disorders that definitely has a lot of stigma still. So hopefully from those videos, you get a little better sense of what people are experiencing who have schizophrenia, maybe a little bit more empathy for that. Again, most often these people are victims of crime. They are not perpetrators of crime, again, on average. So this is something, a type of disorder that's often put in, say, media, and you might have even seen horror movies of someone with schizophrenia hurting people. That is not generally the case. It is oftentimes just a very distressing, very disturbing and annoying and hard for the person because their brain is just not working like they know it should. So with that, there are a variety of causes. There are some brain structures that look like they might be different commonly in people with schizophrenia. It looks like dopamine might play a role in the onset and maintenance of schizophrenia. There might be some aspect of what's happening as the brain is getting to that age and point in its development to lead to the development of schizophrenia. But again, other things like stress, a variety of stresses seem to play a role. So, complications during birth, maternal stress, a lot of stresses can help trigger this as well. Another thing that we see is some illicit drug use does have some correlations here. Again, when you're talking about illicit drug use, you're not taking samples of people and giving them all, say, marijuana or LSD and seeing if they end up having schizophrenia. But we do see for people who use a really large amount of marijuana. And essentially, what we mean by that, I forget the milligrams exactly, but a heavy user is using it at least 5 days a week. Quite a lot in those 5 days. So 5 out of 7 days on average, and quite a lot each of those days would be a heavy user. So someone who's using it for sleep every day is not, and using that much of a dose is not going to be defined as a heavy user, for example. But we do see some of those correlations, but it's still a little bit unclear. I would suspect as we go into the future, if you do an abnormal psych class, you'll see probably a little bit more of the details that it looks like schizophrenia might be kind of our descriptive umbrella, that it kind of fits maybe a couple other disorders under that umbrella that we kind of call schizophrenia. And I think we'll get better and better assessments as we continue on in the future. Maybe if any of you are going into mental health, you might learn a couple more specific types of diagnostic criteria for that. All right, next, dissociative disorders. Dissociative disorders are those that really affect how a person sees themselves or understands themselves to be. So this can be a big memory loss or a change in identity. So a really clear example is dissociative identity disorder that used to be called multiple personality, where you have different clear identities within yourself. That you have maybe multiple, even what we would call personalities, kind of stable traits that are different across. Dissociative amnesia is another good example where you might have forgot essentially who you are, and so now you are a different person. So oftentimes this is a response to extreme stress. It can be challenging to integrate those emotional memories to kind of come back to figure out who you are. With this, there's a lot of evidence that there's underlying trauma that causes dissociation, and this dissociative response might itself be a response to that kind of trauma. So oftentimes this is from childhood, but a lot of people experience dissociation from after experiencing something like war, kidnapping, invasive medical procedures. And so these kind of dissociative states might be psychological coping mechanisms to help protect us from all of that kind of stress. So also things like physical or sexual or emotional abuse. And so this is kind of a response that your brain could take to protect you from those things. And depending on which of these kinds of disorders, again, this isn't an exhaustive list of dissociative disorders, but it affects things like your consciousness, your identity, your memory. With this being said, it's also another one, especially dissociative identity disorder. Most of the portrayals in films are really very poor of dissociative identity disorder. There's a lot of like horror stories and things like that, but just like what we were talking about with schizophrenia, these are people who have clearly suffered something very major and need support and need help, and in some cases might not even realize that they are having these kinds of experiences and having these kind of dissociations, dissociative amnesia. Again, a person might not realize. There's stories of people who, because of a trauma, they completely lost their memories. They went somewhere else, and now a dissociative fugue state, they started a new life essentially. So with that, that's very brief on dissociative disorders. And so we'll also be a little brief on personality disorders. As a reminder, personality is supposed to be something that's kind of stable across time. As we've discussed, it's not as stable as we used to hope we could figure out, like personality traits that were stable and predictive across all situations. But it's useful enough to define these as personality disorders, kind of stable characteristics or traits that a person has in their behavior, their thought processes. So cluster A disorders are things like paranoid, schizoid, or schizotypical, or schizotypal. That one's a hard one to say for me anyway. And these are kind of defined by what people see about their behaviors. And then for cluster B, we see the more impulsive, overly dramatic, things like antisocial, narcissistic, or borderline. We see big changes of emotions that might look overly dramatic, but the people with borderline personality disorder are feeling those emotions at an extreme level. So cluster C disorders, avoidant, dependent, obsessive compulsive, more nervous and fearful behavior overall. So these are kind of stable characteristics across the lifespan where we kind of see them behaving in these type of ways. And I do recommend you either pause the video here or download the slides and look at these to get a little more detail on these specific kinds of personality disorders. For the main purposes of this, while there might be some specific questions on exams about any given personality disorder, I want to focus a little more on just in general. The idea behind these are that it is kind of a consistent pattern of behavior that people are displaying that doesn't fit things like major depressive disorder or bipolar disorder. It doesn't fit things like post-traumatic stress. These are kind of ways that people behave in their day-to-day life pretty consistently that is in some way maladaptive for them, harmful towards other people. So all of these can in some ways be challenging for holding down jobs or sustaining relationships with people or even directly harmful to people or harmful to themselves. And so that's why these are would be classified then as a personality disorder versus you might see some of these symptoms discussed and be like, well, I know someone with that or that, but it might not raise to the level of a personality disorder. So borderline personality disorder is one that is pretty misunderstood. We mentioned it a little bit when we were talking about bipolar disorder. So it's a lot more likely to have quicker flips of emotion. But really, a big part of this is big, more intense emotional and experiencing emotions more intensely. So perceiving slights that and someone neurotypical might not see as very big, or someone who's different with neurodivergence might not see it as a very big thing. A glance that might, who knows, maybe didn't get enough sleep, so their eye was kind of twitching. Someone with borderline personality disorder might possibly take that as some message to them, scowling at them, that they don't like them. And so it leads to some instability in relationships. It can be very hard to be friends with someone with borderline personality disorder or in a family because they might be your best friend in one moment, but then the next day, because of something that you maybe didn't even intend to do or say, or you weren't actually meaning it that way, it's taken in a way that then now you're a worst enemy. So again, this is a kind of consistent pattern of behavior, and it really harms, like keeping jobs. It makes it hard to have relationships as well. And there's a couple really good links here for borderline personality disorder. With the time that we have in class, I don't think that we will look at them in detail, but they are linked here in the lecture slides. I do have a video that I intend to look at as we get into treatments. One example, there's a specific cognitive behavioral therapy that was specifically designed for people with borderline personality disorder to help them learn to regulate their emotions, like step outside themselves and look at their reactions to the situation, see if they can really make the assumptions that they're making, these kinds of things. So there is a little bit of some people with experience of borderline personality disorder, but I definitely recommend looking into these resources if you want to know more. Similarly, for antisocial personality disorder, this is oftentimes people who are disregarding other people's rights. They're being impulsive, irresponsible. They don't seem to have any remorse. And oftentimes we see that with antisocial personality disorder, it is one that is more predictive of harming other people versus pretty much all the other disorders. You're more likely to be a victim of crime. This is the only one that is really more likely to be harming others more directly. Again, you don't have to be necessarily. You can also just be rude to people. Right? You don't have to be doing major crimes with antisocial personality disorder, but it is definitely one that is misunderstood. Here with it, it does take a lot to diagnose this. To see if they're meeting all those criteria. And this is just a brief discussion here in the slide about what antisocial personality disorder, but if you think of someone who's pro-social versus someone who's antisocial, who's doing things that harm others, often for the good of themselves, that is an example of being antisocial. All right, we do not see it too much, but it is observed in about 3% of the population. So again, while we don't have time to go over all of these in detail, some of these are more detailed than some of the material in your book, so I definitely recommend pausing the video, reading some of this material. So here's some predictors or risk factors to look for. And looking at, did they have, say, a parental violence? Were they delinquent in their peers? Were they in poverty? These kinds of things can be predictors. All right, so neurodevelopmental disorders. So these are ones, a lot of these actually fall under a newer term called neurodivergence. But let's talk really quickly about two main ones that a lot of people know, but these aren't the only ones. Again, most of these lists that I'm putting up here are not exhaustive lists. So two really common ones that people know about are attention deficit hyperactivity disorder, or ADHD, and then autism spectrum disorder. So with this, these are oftentimes seen in childhood and diagnosed fairly early on. In women, it tends to be diagnosed later than in boys. So ADHD, you probably have some ideas in your mind of what someone with ADHD kind of looks like, but it really is It really is caused by things like genetics. There might be some brain aspects to it. There might be some different things in prenatal development that are correlated to it or even causal. But ADHD is not caused by sugar. It's not caused by food additives. It's not caused by specific parenting styles. But here, a major aspect of this is executive function. So that attention and being able to focus attention, being able to pull attention off of one thing or onto one thing intentionally. The A lot of activity, oftentimes you might see it as hyperactive or impulsive behavior. So with this, there are a lot of good treatments. This is actually a really great video, is about 20 minutes long. So a good one to look at if you're really interested in learning more about specific treatments, but we will get a little bit into treatments in chapter 16. So with that, autism spectrum disorder is a big category that includes a lot of different disorders and symptoms. So a couple key points in autism: often sensitivity to sensory information, again, lowered executive function, and so that might appear similarly or different than we saw executive function appearing in ADHD. And oftentimes this is diagnosed in earlier or middle childhood, but for women it's usually diagnosed later. So it does seem there's a lot of genetic factors. It's not entirely genetic, but there's also other aspects of the environment, epigenetic factors, things like mercury that are correlated here. There are also differences in brain structures and neurotransmitters that we see in people with autism. So it's also not super clear exactly how it's caused and what kind of recipe of those risk factors leads to it. Another thing to definitely bring up, because this is a very clear thing in research, is that it's not caused by vaccines. So that is something hopefully you already knew coming into this class. If not, definitely take a look at any literature reviews now that you know how to do research and find research papers. Look at any kind of literature reviews, peer-reviewed papers, book chapters on it. But when we talk about an autism spectrum, what is the spectrum? A lot of times we think of a spectrum as kind of like this. There's maybe mild autism versus severe autism. So maybe here a person's completely nonverbal versus here they can hold down a job and seem kind of neurotypical. That's often how we think about it. But the spectrum is a lot more like this. There's common types of symptoms. This is the same for a lot of these disorders too. So I'm bringing it up in more detail here, but this is true for even things like schizophrenia. Those various symptoms, you might have one that you have or you don't have, and another person does have or doesn't have. For ADHD, there might be aspects of ADHD that you struggle with more or struggle with less. Every individual person who is neurodivergent is different in different ways. All brains are different. That's the idea of neurodivergence. So for any given person with autism spectrum disorder, they might have difficulty finding words, or they're able to find words really easily. For motor skills, they might be bumping into things regularly or not bumping into things. For sensory, they might not really have much problem with sensory information. But for others, sights, sounds, like lights might be really uncomfortable for them. because of the way their brain is processing these things. Again, executive function, maybe it's really difficult to plan, really difficult to focus, or maybe that's not a challenge that they have. And this can change and be a little more fluid. You've probably experienced this yourself, even if you're not neurodivergent, sleeping more, sleeping less, eating or not eating. You've probably seen some of your mental capacities change. Also, for someone with neurodivergence, while there tends to be a pattern in any given individual over time that they, in their sensory inputs, they're more it's heightened for them or less heightened for them on average. That can change day by day with other inputs in the environment. So that brings us to a main topic of neurodiversity. Basically, a lot of the things that we're talking about are the brain working a little differently than we would typically expect. So we would expect on average. So when I say neurotypical, I'm talking about what we kind of expect on average for humans' brains to be doing. So ADHD, autism are really good examples of neurodiversity, that the brains are interacting with the world in slightly different ways. So some people's neurons are wired a little differently. Some people's are wired more similar to other people. And that's the idea of neurodiversity. People experience and interact with the world in different ways. Brains are set up just slightly different and slightly similar to one another, and that is true across the board. And so when we say someone is neurotypical, it seems like they are closer to that average kind of typical pattern. That being said, there isn't one right way of thinking, learning, behaving. Just because you have a little more or a little less difficulty in paying attention or focusing attention doesn't mean that that's wrong or bad. It's just how your brain works. And if you're wanting to use that skill and it's hard for you, it's something you can maybe learn to change or have medicine to help you with. It could also be to a degree where it really disturbs your life and makes it really hard to do things. So as an example of this, let's watch a little bit of this video of a person who learned about their neurodiversity later on in life.
My name is Elisabeth Wiklander, and I am autistic. What do you think about when you hear the word autistic? How do you react when you hear the word autism? Would you say that it is a lifelong disorder, an impairment, a disability? This is indeed the way medical language describes it, but autism is so much more than that. No diagnostic manual can truly explain the multifaceted experience of autism. It is a neurological difference with a vast spectrum of representation within its population. It can come with remarkable gifts and skills, as well as devastating traits. But autism doesn't necessarily equal disability. And thankfully, today we have a word that challenges this negative terminology: neurodiversity. Neurodiversity describes how diverse we are as human beings from a neurological perspective. It suggests that the many variations of human brains, like autistic ones, should be accepted as a natural and valuable part of humanity's genetic legacy. DNA shows us that autism is primarily a genetic condition, something that has been passed down through generations and is still widely shared in the general population. These genes can carry something so positive, in spite of the difference they cause, that they have persisted throughout our evolution and still flourish today. Some of our important inventions, pieces of art and music, and discoveries in scientific fields that have moved our world forwards come from autistic minds. With today's exciting new technologies in neuroscience, we have seen that autistic brains differ from the norm. Not only that, but it appears as if each and every one differs in its own unique way. So, autism is rich in expression, but still faces limiting generalizations. Today, I want to talk about the autism that I display, the one that blends with normality, and can have catastrophic impacts on people's lives, not necessarily because of the autism itself, but because of the ignorance of it, or the failure to recognize that it is there in the first place, as I eventually would discover. Now, in social situations, we do have expectations upon one another. We use a certain kind of rule book, which, when followed, rewards us with social acceptance. But I always felt that I was different. The trouble was I couldn't explain how, and certainly not why. It felt as if I had been provided a different rule book, and that I lacked a community to fall back upon that could confirm to me that the way I interpreted the world was valid too. So I grew up feeling very misunderstood by pretty much everybody, even within my own family. If I applied what would have been my motives, my intentions, upon someone else's behavior, or vice versa, the outcome was often negative and very confusing. So to me, the social world became scary and unpredictable. Now, I did notice, however, especially during my school years here in Sweden, that my mind had been blessed with gifts, like analytical skills, an intense mental focus, high capacity for memorizing information, which made studying very pleasurable and easy. So in my academic pursuit, I came here to Gothenburg, where I studied at the university. I later went to the Netherlands, where I attained my Master of Music. And today, I live in the UK, working as a professional cellist in the London Philharmonic Orchestra, touring the world. But this, however, is quite unusual for me, to stand on a stage just talking to you without my instrument. I can't help the feeling that I have forgotten it somewhere. Okay, so one may now think, okay, she plays in this great orchestra. She's obviously done pretty well for herself. What's the problem? Well, I have a very literal mind. And it constantly clashes with both non-verbal and verbal subtleties in social situations. It gives me a very direct line of approach and speech in everyday conversations. I still don't really understand the purpose of small talk, although I can appreciate it now. And jokes and sarcasm fly completely over my head. My mind just takes things in so literally. It loves to analyze everything. My world is a very intense one. My senses are heightened. My brain absorbs everything in through an amplifier. My special interests can completely consume me. And my emotions, they go from the highest of high to the lowest of low, and they're on and off like a light switch. My family, bless them, they can still stand in utter disbelief when I go from a complete nuclear blast to rainbows and butterflies in less than 2 seconds, literally. So, okay, autism influences my thoughts, my imagination, my senses, my emotions, and the way I process information. But without knowing this, it was very difficult to maintain friendships because our social expectations were so different. I could come across as odd, and I experienced a good amount of bullying for it. But the most devastating were the eroding misunderstandings that dominated the relationships with the people closest to me. Body signals, misread. Words, completely misinterpreted. It was so frustrating. It was like fighting a ghost, something that no one could really grasp, not even the counselors we sought for help. So it was a mentally agonizing situation that persisted year after year. And in my mid-20s, I had reached a really dark place. And I started to be truly scared for my future. But then, something extraordinary happened that changed everything. In 2006, I heard about Asperger's syndrome. It is already an outdated term today, but it is still a form of autism on the high-functioning end of the spectrum. 3 years later, when I was 28 years old, I received this diagnosis. And I realized that a good third of my life had been based upon a false perception of myself. Imagine that. No wonder my life had been so confusing. But now I started to see myself in a new, clear context. My whole life and all my experiences just started to make sense.
Really great example there of the experience of someone who didn't realize that they were neurodiverse throughout their lifespan, and a lot of good descriptions there about how they experienced their symptoms specifically. And that's one thing that's sometimes hard to get across, is exactly how they experience their symptoms. How is it different? So when thinking about these different symptoms and looking at this spectrum we were talking about, you can see that they fit a few of these things, that some of these things are harder or easier for them, that's the way their brain works. And the idea with neurodiversity is that people's brains do work differently. No one type of brain is better or worse. All humans are valid and valuable. All types of brains are valid and valuable. A person who is not able to speak at all and create words is still a valuable person and worthy of respect and love. A person who is able to stand on a stage and speak is also a person who is worthy of respect and love. That these different aspects of how our brains work doesn't make us a better or worse person. And that's the basic idea behind neurodiversity. Another thing that, going back to the beginning of our lecture today in chapter 15, really ties in is that diagnosis really helped them. They go on to talk about how they started reading more, how they started joining like groups on social media to learn more about how other people are trying to help with their autism. And in the end, they kind of realized one big thing was that they wanted to do advocacy and talk to people about autism spectrum disorders, the experience, what it's really like, to help people understand that what people are going through in their own brains. So all of these things that we've been talking about can fall under that umbrella of neurodiversity. Neurodiversity can appear for a shorter time and then also go away depending on what it is. So anxiety and depression can change the way that your brain is working, can change your ability to pay attention, can change your ability to focus, can change your ability to interpret what people are saying around you. These are aspects of neurodivergence, that brains can work differently. And some of these things, anxiety and depression as examples, can go away, right? Something like dyslexia or dyscalculia or dysgraphia, they might not go away your entire life. It's your brain processing the language, and the written language specifically, different. Things like autism or ADHD or even personality disorders, even things, I think it's on this, of schizophrenia. Schizophrenia and the symptoms there of your brain working a little bit differently. This picture it's obviously not an exhaustive list, but the symptoms of schizophrenia would also be classified as neurodiverse. The brain is processing things differently. And so that's a big thing as we go into the chapter on therapy, that therapy tries to work with. If these changes of your brain, these things that it's doing that are different than neurotypical, are tough for you, make life harder, make it harder to hold a job, hold steady relationships, that is a big reason for therapy, because in some of these cases, you can learn strategies to work around these changes of your brain, the difficulty of your brain. If you have a lot of trouble with attention or language or with whatever aspect of it, a negative loop for rumination on depression or an anxiety loop, there are strategies that you can learn to implement to help your brain, one, start a new loop or change that loop. Or in some cases, learn new strategies when that is happening so that you can continue on with what you're doing, right? So you don't hurt your relationships, or you can keep focus on your work, whatever it might be. So the main idea with neurodiversity is brains are different, humans are valuable, brains are valuable, and with this idea of neurodiversity, it kind of expands our ideas of, yeah, people have differences in their brains. And yeah, we kind of have these averages that we expect for neurotypical, but people don't always fit that. You might be neurotypical in some ways and neurodiverse in other ways. And some of those cases, it's going to be to the point of having a diagnosis like schizophrenia, autism, dyslexia, ADHD, a personality disorder. And that is why we jump to chapter 16 for therapy and what therapy can do. So both medicine, both talk therapy, some of the psychosurgeries we'll talk about, a lot of their focus is to help the brain rewire or train a person to learn new skills to accommodate themselves in their life. But hopefully, this discussion also gave you a lot more empathy in the kinds of experiences that people have who are suffering from disorders, gave you a little more clarity on things like schizophrenia or dissociative identity disorder, so that you understand a little bit more, especially with hearing the words of some people struggling from these things, how challenging it is for them, and that you can understand that a little more and be a support. And when you see some of those negative media portrayals, you understand that that's not what these kinds of people actually are going through on average. They are having a hard time, just like a person from depression. I think there's a lot less stigma, a lot more support for people that are going through depression and anxiety. So hopefully we can build that in the world for a lot of these other challenges that people are facing.